Welcome to Be Well with MS podcast series, where I and expert guests discuss science and science-based tools for everyday life to preserve brain health and quality of life living with MS. I'm Dr. Agne Straukiene, neurologist, researcher, innovator at Torbay and South Devon NHS Foundation Trust in the UK. So today's guest I'm very excited is Professor Gavin Giovannoni, who was appointed to the chair of neurology, Blizzard Institute, BARS and the London School of Medicine and Dentistry, Queen Mary University of London in November 2006. His clinical interests are multiple sclerosis and other inflammatory disorders of the central nervous system. He's particularly interested in clinical issues related to optimizing MS disease-modifying therapies. Professor Giovannoni's current research is focused on EpsteinBarr virus as a possible cause of multiple sclerosis, MS-related neurodegeneration, MS biomarker discovery, MS clinical outcome measures, MS clinical trials, and immune tolerance strategies. He has recently become the co-director of the Preventative Neurology Unit at Wolfson's Institute of Population Health. It's very hard to summarize Gavin's bio in a short period of time. He does so many things and is very well known and established neurologist in the world. If you don't know who's Professor Gavin Giovannoni, either you don't live or you have no access to the media or other educational events. I'm also very biased of his influence on me. I have to admit, Gavin is my guru and inspiration that took a lead of my career years ago. And without Gavin's inspiration, I would have never started running these Be Well with MS podcasts. So I secretly use my network and I run a survey and I asked his colleagues and peers to describe Gavin in 2 words. So here you go. Are you ready, Gavin?
I'm ready, yeah.
So, people say he's a friend, a mentor, encyclopedia, motivator, challenger, thinker, sounding board, etc., combined with being kind, honest, funny, and a great company socially. And with all that, he's a regular guy. Some other colleagues pointed out that he always striving, determined, inspirational, a legend, bloody lush, super fit, MS king. And that continues on, trailblazer, because he's not affected by whether people like him or not. He knows what needs to be done and just gets on with it regardless. A superstar, Top Gun. Got an insights, visionary and assertive, yin and yang, change champion, educationally controversial, and so many other comments that I run off my paper and pen to list it down. So ladies and gentlemen, welcome to the show, Professor Gavin Giovannoni.
Well, thank you, Agni. Do you do this for all your guests?
Oh no, this is very special for you, Gavin. I also contacted your family members via Facebook. They actually haven't seen my messages, but I wanted them to comment in 2 words who you are for them and what is your personality like. However, they haven't read my messages, and if they had a chance to read it, please welcome them to comment directly to you face to face. This is just a reflection, Gavin, how much we love you, and we really excited to have you as a friend, as a colleague, and it's such an opportunity for us all to always lean on you, come back to you, ask questions, discuss very challenging cases, as we all do, and such a pleasure to have you on this show. So today we are going to talk about the comprehensive MS, multiple sclerosis management, and what is the minimum we need to do for our patients and patients themselves to preserve the brain health. As you know, the International Panel of MS Experts has proposed the creation of the new framework redefining how different types of multiple sclerosis are described. What and why it is important for MS community to know about this change and how to act accordingly.
Well, I don't think they've changed anything yet. All they've done is, review the literature and come up with a model to try and explain what happens in multiple sclerosis, particularly over time, in the terms of the trajectory of the disease. And I think I think we all as a community are beginning to realize that in the past we had this two-stage disease where we had a so-called inflammatory phase and then a degenerative phase, which is, was called the progressive phase, is wrong. And I think we've known that for a long time, actually, is that these two phases are on top of each other, exist in parallel. And there isn't two phases to this disease. There is one phase. MS is MS, and there is inflammation, and there's ongoing damage and degeneration, and they occur in parallel. And I think what dictates when we see the so-called progressive phase is simply resilience, how much reserve is behind. And when we run out of reserve, what we see then is what we call a progressive phase. But that phase starts very, very early. It's actually there before you even get your first symptoms. This disease is there, and there's a pre-symptomatic phase to MS, and it could be up to a decade. We're not sure exactly how long it is in individuals before you get your first symptoms. So all they're doing is creating this framework, and it's going to have implications in terms of how we do trials and how we approach treatment and how we manage this condition.
It's really important that describing MS based on underlying biology rather than just quantifying and defining clinically, it requires a better understanding of the mechanisms that drives disease worsening. If we had a good understanding of the underlying biology and the cells that participate in the pathogenesis and physiology of the MS, perhaps at this time point we probably would have a treatment and a cure for MS, but we don't. And it's still under a lot of investigations. I know, Gavin, that just before the ECTRIMS 2022, you did the survey, and you asked the questions around the MS classification, and what do we know? What are the results and outcomes following this survey that you run in the UK? What MS community thinks about this new framework and classification?
Well, I think we should just go back a step, and the community should understand that the classification system that dictates treatments, having relapsing, remitting, secondary progressive, primary progressive, and then there's also the subtype called clinically isolated syndrome when you just had one attack, which is kind of disappearing because we make the diagnosis a lot earlier. So there's very few people now who have CIS, clinically isolated syndrome. But that classification system wasn't based on biology. It is based on a business decision with the FDA, the Food and Drug Administration in the United States. There's a thing called the Orphan Drug Act where you can get a drug license for a disease if there's fewer than 200,000 people in the United States. And with MS, there was more than 200,000 people. So the only way that they could make it an orphan disease, if they sliced it up into 3 different categories, and in each category there was less than 200,000. And that's how interferon beta, the original disease-modifying treatment, got licensed. And the Orphan Drug Act allows you to license a drug with one trial. And that it gives you market exclusivity for, I think it's 7 years in the United States. In Europe, the similar thing in Europe gives you for 10 years. And it prevents competition coming in. And the whole purpose of the Orphan Drug Act is to try and encourage companies to develop therapies or drugs in diseases that are neglected. And the consequences of that, though, is we had this classification system that is not linked to biology, to be honest with you. It's linked to an artificial classification system that needs to get rid of. And so when we did the survey, I think we got the impression from all our colleagues is that they all agree with us, but nobody knows how to address this. How do we go back from 3 diseases in inverted commas to the biology of the disease and say, you've got MS, and we need to manage it based on the biology. And the implications are very obvious. People should be on an anti-inflammatory therapy to try and dampen down the inflammation. And then we need to build on top of that other treatments to target this process of degeneration that's occurring. So there are other mechanisms within the brain that we have to target that our anti-inflammatory therapies don't work on. So there's lots to be done. And so I think this the thinking has profound implications for how we manage MS and also how we develop therapies in the future.
This is wonderful, Gavin. And are we as a MS community ready to change and update the McDonald's 2017 criteria?
Yes, I think so, because a lot of your listeners will know that there's this condition called radiologically isolated syndrome, which is basically asymptomatic MS. This is when people go off and have an MRI scan for another reason. could be for a headache, it could be for a head injury, it could be for screening to go into the military. So, for example, in Germany, you can't go into the Air Force without having an MRI scan in case you've got something that stops you being a pilot, for example. And you pick up people that have lesions on their brain that look very much like MS, and they haven't got any symptoms, and we call that asymptomatic MS. Now, there's just been a trial, it's just been published in the Annals of Neurology a few weeks ago, pre-publication. It's not yet in print, but it's on their website, showing that one of our therapies, dimethyl fumarate, actually delays the development of MS. So we've got treatments now that work in asymptomatic MS. I think we're going to have to update our classification system. We have to start defining MS as starting before, and we'll have to include, I think, asymptomatic MS. Then, as you know, Agne, there's been a lot of new developments that are quite on MRI scanning in particular, that could make the MRI criteria more specific. In other words, mark MS, because one of the problems we have in MS is misdiagnosis. People will be, surprised to hear that about 1 in 20 people who are labeled and diagnosed as being MS have another disease. And so one of the things is, for example, there's this thing called the central vein sign, which you'll know about. But what it means is in the MS lesion, inside the lesion, there's a vein, and that's quite specific for MS. And so, we may see inclusion of these particular new signs on MRI scanning incorporated into the diagnostic criteria to make them better. In other words, to make it less likely you misdiagnose somebody who doesn't have MS having MS. So I think, yes, there's lots of new developments that will be required to be incorporated into the new diagnostic criteria.
I guess if we have a specific tools to define the accuracy of the MS diagnosis, the actual disease following the lumbar puncture, specific MRI scan features that would support the diagnosis biomarkers, that would give us even more accuracy in our diagnostics, how wonderful that would be, because we have some cases that, we're not sure, we're not certain about whether this is MS. Some MRI scan findings with white matter disease may look like a small vessel disease, and we may be so wrong if we are not so careful. And we are in 21st century living life, and we are now in 2023. So I think we really need to push that pressure, and as a community of all the healthcare providers, come with a conclusion that we have to have a bit of an update on the criteria to make us more at ease, to feel better, be more accurate and more robust in making the clinical decisions, because that involves the biologic agents, and it might be so harmful if we are exposing unnecessary patients with other neuroinflammatory disorders, not MS. So now, Gavin, I would like to know, what do you call comprehensive MS review? What does that involve? We have such a limited time in our clinics, under a lot of pressure, in and out the clinical setting. How does that work, and what is the comprehensive MS review?
Well, I think I like to call it an MOT after, when you take your car in every year to get MOT to make sure everything's working all right. So obviously, we tend to have been focusing on disease-modifying treatments. And I think that needs to just happen anyway. Is this treatment working? And to show that it's working, and I talk about anti-inflammatory effects, you just got to make sure people have had no relapses. And if they have suggestion of a relapse, you look on the MRI scans to see if they've got new lesions. In other words, is this treatment failing them? And obviously, you've got to make a decision about, do they need to be on a more effective therapy? So that's one decision-making process. And then obviously, as you know, different therapies we use in MS have different adverse event profiles. So you've just got to make sure at that comprehensive assessment that you're checking blood counts, you're checking vaccine responses, whatever it is, to make sure that you're trying to minimize the adverse events. We call that pharmacovigilance. It's just basically being very vigilant around the potential adverse events or side effects. That's that side. But then what we've got on the other side are all the symptomatic problems, be it hidden, in other words, you can't see them, or not hidden, that you have to address. And there's a comprehensive list of things you need to do there. I mean, I tend to start off with the ones that cause the most common. Are the patients got bowel and bladder problems sorted out? Are they sleeping well at night? Are they depressed? Is there anxiety? You've got to go into pain, spasms. walking ability? Are they at risk of falls? What's their bone health like? And then you've got the other side, which is the brain health issues, and that takes time. So one of the things you have to ask, do these people understand about lifestyle management? Are they eating well? Are they smoking? How much alcohol they're drinking? All the things that go into brain health, and it's also comorbidities. So you got to just check to see if these people are overweight. Is there something you can help them with in terms of their diets to lose weight? Are they exercising? What's their blood pressures, et cetera, et cetera? So there's a lot to do in a short period of time. And this is why I think the current model of seeing people and trying to do this in 15 minutes with a follow-up is just not appropriate. So, one of the things I think in terms of how our healthcare system needs to evolve, we need to do this asynchronously. In other words, where you don't have to see individuals, so you give them tools to actually self-manage, and you educate them to self-manage, or at least try. I think this is what you're trying to do in your service as well. And they don't need to have an interaction with a healthcare professional necessarily to do certain things. So let's give you an example. One of the things is foot health. Okay, it's very neglected but I think that if somebody, and I'm talking about people who are more disabled now, they can't cut their own toenails or wash or look after their own feet, and they usually have to rely on somebody else. And in the NHS, we have, foot hygiene or podiatry clinics where people can go to. So what we do in our center is we allow self-referral, so within the community, there are self-referral foot clinics. So if somebody is disabled and they can't cut their own toenails, they can self-refer in to podiatry. And that's important because, it sounds ridiculous, but, having poor foot hygiene is a risk factor for falls, and it's actually telling you a lot about that individual as well. It's kind of like an integrator of not being looked after properly. Maybe not being able to look after yourself because you're disabled, but not having the right network or support in the community. So it's something that I add to my list now. I try and look at people's feet at each clinic, and I make them take their shoes and socks off. That's interesting because some people come in, they're beautifully groomed, they put makeup on, they look great, and you look at their feet and you realize it's a show. They've come in and they haven't really they're not really coping at home. And then the other thing, Agne, which is really important post-COVID, is to focus on wellness. And wellness is more than just health. So this is how you interact with your society. What's your social network like? Are you socially isolated? Are you lonely? Are you getting to see family and friends? Are you connected to the internet? Do you have a telephone? All these little things that make people function in society. So, and then we also ask the question very simply, are you coping? Are you coming out financially? Now, we as doctors, healthcare professionals, can't sort out the social problems, but we've got in our local boroughs, there's actually a referral system for social prescribing, and we can signpost these individuals into that, and then there's a whole community-based team of people that help them. And this is actually becoming critical now, obviously with the financial crisis that's happening and the energy crisis, that there are lots of our patients, like the other people in society, are just not coping financially, and there are things that can be done, not from a healthcare professional, but from a social services perspective.
I totally agree, Gavin. And the only one thing that I could add here is that we probably need to look at the polypharmacy. There are some medicine that we use for spasticity management, such as pregabalin, gabapentin, and baclofen. It causes a lot of drowsiness and fatigue and weight gain. So really paying attention and spending a bit of time, although we have limited time during the clinical consultations, but a bit of doing some adjustment and optimizing the polypharmacy and rationalizing whether it's appropriate for individual cases is required. I also noticed that there is a gap between the stools. Patients are being managed by the primary care physicians and ourselves, so sometimes there is a miscommunication between two of us, such as we assume that comorbidities, health checks and MOTs and blood pressure monitoring, diabetes and all the rest should be managed by the GP doctors despite the age. and GP doctors who think that this young patient under neurology services, MS centers and services, they should be managed fully by neurologists. So sometimes there is a bit of a gap who's managing what, but I think we need to collaborate on this note quite nicely together. As neurologists, we are not trained to look after blood pressures and diabetes management, so we really need your input as a primary care physician. And of course, we are focused on the brain health, and this is where we stand with our approach. But highlighting the issues, noticing that there is a problem, and referring that back to the GP, communicating if there is something that could be done at the secondary care, tertiary care hospital. So that's how we probably should arrange things and for patients' best interest to preserve the general health and to preserve the brain health as a consequence. And I think that other aspects that I often think about, and I'm not sure whether we are providing the service, but we probably should reflect a little bit more about the women's health these days. And I often think about the women who are disabled with severe spasticity. They're not necessarily getting smear tests because of the increased spasticity in the legs. And maybe there is a way of working together with gynecologists and running the MDT type clinics where we assess the patient and do some interventions at the same time, or maybe linking with the Botox clinics and the gynecologists that could run clinics alongside us. So some reflection of how we should maybe implement new changes within the services and is something that we could pursue and go forward.
Well, to be honest with you, I try and address the women's health questions as part of my pro forma. So, in younger women, I always discuss contraception and family planning and their what they're planning to do, because and then older women, I always discuss menopause, and I always, because my recommendation is, unless it's contraindicated, every woman with MS who's menopausal should be on HRT. There's no reason why you shouldn't be on HRT. From an MS perspective, there's so much evidence mounting why you should be on HRT. So I do that. And even when it comes to younger women who are still menstruating and having problems with personal hygiene, I recommend to the GP to suppress periods, either by putting in a Mirena coil or putting them on a long, continuous progesterone. So I actually, I don't manage that myself, but I put it into my letter for the GPs to do that. But the idea of having a gynecologist in it would be potentially ideal. But to be honest with you, it'd be quite difficult in our environment to sort that out, to get a gynecologist to do a clinic in parallel. I could understand us referring them to a gynecologist, but a lot of these women's health issues are general practice issues, don't you think?
Yes, I totally agree. But we have to appreciate that we are under a lot of pressure, as well as the GPs. They experience a lot of workload at the moment, and to navigate through it is quite challenging for both, I guess. But maybe sharing that workload might feel a bit lessened, and then establishing the pathways that could work. And if you have a pathway already locally, please share with us with your best practice. We would appreciate learning from you and learning how we should best address the women's health.
And one of the other things about women's health, Agne, is the issue around HPV vaccination. So a lot of women now who are getting missed out on the national HPV vaccine program, and even most of the young women only got the Gardasil 4, which is the covers for the HPV. And so there is this option of upgrading to the Gardasil 9. So, I spent a bit of time. The point about it is we just don't have time to do this. And that's one of the reasons why I launched a thing called MS Selfie for MS self-management, where I try and go over these issues for the broader MS community so that they can then self-activate and potentially sort that out themselves via their GPs or whatever, because there's just so much you can do as an MS consultant in an MS clinic when you are so overworked. I'm sure you're as overworked as we are. We don't have spare capacity, at the neurologist level or the nursing level to do all these things.
My other question is, I know that you're a strong believer that EBV virus is potentially a cause of MS, and there are some heated discussions around this topic. So does that change your practice now? Do you discuss that with patients, in particular newly diagnosed patients? Do you check the titer of EBV?
I mean, all I tell people is we think that Epstein-Barr virus is the cause of the disease. We don't know how it causes the disease. So there are two competing theories. And there's nothing you can do about it because, 95% of the adult population is infected with the virus. And the virus actually may play a positive role in human evolution. It may provide across the general population, it may boost immune memory, for example. And all I say to them is we are working on, as an MS community, and is on a vaccine strategy to see if we can prevent MS in the future. That's going to take 20 years to get that answer. And then there is, in people with the disease, there is a theory that the virus keeps, because as you know, it's a herpes virus, and it's got two phases. It lies dormant in a latent phase, and then every now and again it reactivates. And we think that this latent what we call latent lytic, when it reactivates, may be part of what's driving MS. And we're trying to get clinical trials off the ground of antiviral agents. So, and that will happen over the next decade. They're already starting, to be honest with you, are various different strategies to target the virus. And, I just say to people, watch the space. If trials get off the ground, you may be interested in participating in those trials, because I think it's really, really important we develop or test the hypothesis of antivirals in MS. And I think that will happen in the next few years. We're going to have antiviral trials coming along.
Oh, that's great. Are we in the position to offer people with MS remyelinating agents? Where do we stand from this perspective?
Yes and no. So the best way to get remyelination is to treat MS early and effectively. Okay, so we now know that if you get on top of MS really early in the disease, before people become disabled, you get quite good recovery of function. And we think that's got to do with age and the fact that by suppressing inflammation, you allow a spontaneous recovery to occur. Obviously, when you start talking about people with more advanced MS, as you get older, the recovery mechanisms deteriorate and don't work. But what we're not doing enough of is using what I call the biological stimuli to promote recovery, independent of therapies. So this would be exercise and targeted rehabilitation. So just to give you an example, if somebody loses function in a hand, they've got to use that hand to get back, and we just don't have enough active rehabilitation programs. And now one of the problems we had in our clinical trials, and we've been very disappointed. We've had 4 different therapeutic strategies fail in the recent past of remyelination therapies, which we think would work because the biology is quite, well studied. But what we didn't have in the trials was, everybody should have been given an exercise rehabilitation program. And the thing about exercise rehabilitation programs, it's not one for everybody. You have to personalize it, and that makes it very difficult to include in trials. So rehabilitation has to target disability. So there's no point in doing running if your disability is vision or cognition. You have it. So this is one of the things that's quite difficult to implement that in clinical trials. But I do think that we are missing out on a trick here, because I think if you look at the evidence, exercise is probably one of the most effective add-on disease model. I'm not saying it should be alternative, it's complementary. So exercise is probably one of the most beneficial add-on therapies we can offer MS patients.
Yes, and we've got a separate podcast on brain health and exercise, the benefits and the impact on the brain health living with multiple sclerosis. I interviewed Dr. Andrea Stennett, and we tackled a lot of aspects, how beneficial exercises are and how it improves the neuroplasticity and the function, and overall the outcome of living with MS is much, much better if you do exercise. So tune in and listen to that podcast. Now, Gavin, I would like to move on and ask a question. What is that you have changed your mind about in the last year, and why in MS management and maybe perhaps underlying MS biology?
Yeah, so one of the things that I have changed over the last few years is you talk about reviewing medications, is to try and get people off anticholinergic drugs. So these are drugs that go into the brain and block a chemical called acetylcholine. Okay, and we now know that they really are not healthy. They are really bad for the brain. They not only affect cognition, but they probably affect plasticity mechanisms and synaptic function. So one of the things I try and do now, and this is common drugs we use. This is bladder drugs for, anticholinergic drugs for the bladder. Amitriptyline. So amitriptyline is like, neurologists hands out amitriptyline like Smarties. It helps people sleep at night. It helps bladder dysfunction. It works in anxiety and depression. And I'm not joking. I would estimate that about 1 in 3 people with more advanced MS are on amitriptyline. And so what I'm trying to do is get them off amitriptyline. If they do need an antidepressant, is to go to one that doesn't have anticholinergic effects. And if it's been used for pain, because then I use duloxetine now, which is it's also an antidepressant, but it's got much less anticholinergic effects. So that's one of the things I do change. I'm trying to get people off anticholinergics. The other thing I've tried proactively manage is try and prevent infections. People who get recurrent infections, particularly bladder infections, that they do badly. And the reason for that is infections obviously trigger inflammatory mechanisms in the brain. And so we have to proactively prevent infections. And that's not only bladder, by the way. It could also be chest. And the one that we're missing out on is periodontal disease. It's inflammation in the gums. And that's a very common problem in the UK. People have poor gum health. And outside of MS, in other disease areas like cardiovascular disease, even rheumatology, periodontal disease is a big driver of worse outcomes. And so I think, I'm increasingly referring patients to our dental clinic now for periodontal disease. So I'm become more proactive on infections. Really something that needs to be proactively done. What I've changed my mind over the last, I wouldn't say a year, but 5 years, is that we shouldn't give up on people when they become wheelchair bound. I don't know if you're aware. NHS England and NHS in general says you've got to stop treating people with anti-inflammatories when they reach a wheelchair level. Because when they did the clinical trials, people in wheelchairs weren't included. But that's ridiculous, because at the end of the day, MS continues, and you've got upper limb function, and you've got swallowing, speech, cognition, hearing, vision, all those other things have to be protected. So this concept of having to not treat people because they're wheelchair bound is just, incompatible with what we know about MS. So which is why we're doing trials now, including people that are, wheelchair bound, to see if we can modify their disease and protect upper limb function. Because as you know, once you're in a wheelchair, your arms are your legs, and these things keep people independent, So, once you lose upper limb function, then you are dependent on carers 24 hours a day. I just can't understand the NHS the stopping criteria are not evidence-based. A lot of other countries don't stop treatment when people get into a wheelchair; they continue them. And I think we need to seriously address this issue with trials and with data, so we can, tell the payers, NHS, we should continue managing people proactively, even when they are more disabled.
Yes, I quite often say to my patients, you can live without legs, but without arms and hands, it's quite a big challenge. So if you still have preserved arm and hand function, that's your main focus, to improve the function or maintain the function as it is. So Gavin, I know that we all know that you're very, very successful, you're a high achiever, you've done so many things in this life, and I would like to know whether you ever had a failure, any apparent failure that later on it sets you up for a success. What is your favorite failure?
Yeah, so to be honest with you, let's be frank. I moved from the National Hospital Queen's Square to where I am now in 2006 with the specific aim of setting up MS prevention, EBV, and all that kind of stuff. And it just became impossible. I got one big grant back in 2008. But since then, I've just had one rejection after another. So I consider that a failure, that I haven't been able to convince the funders and my colleagues that it's worth funding EBV research. So that's been a big failure. I'm hoping to change that now, because I think we get a bit more momentum. So now I think the funders may think we've got to spend. So that's been a big disappointment in my professional academic career, is that I haven't been able to convince people about the MS EBV hypothesis. The other failures are systems failures. I have guilt. I've got skeletons in my closet like everybody else around delayed diagnosis, delayed treatments. And, I look at these patients when they come to me, and I think, if you were diagnosed earlier, or you were put on treatment earlier, you wouldn't be as disabled as you are. So I have a lot of those guilts, and you can say, it's not intentional. These are just systems failures, and that really upsets me the most. And we're still failing large numbers of MS patients in this country by just the systems problems. You'd like to get these people through a diagnostic pathway in days, not weeks or months. And one of the things that was highlighted to me, as part of the MS Academy, some of the people who attend the MS Academy, which you teach on, I did audits. So for your listeners, there's a thing called the hub and spoke model. Some people go into the hub, which is the specialist unit, directly, and on average they get onto therapy. It takes about 8 to 12 weeks to get onto therapy. If they go through the spoke, and then they got to get referred into the hub, there's a delay in getting in, and those people get onto treatment at about 9 months later. And in that 9 months, there's a large number of these people that have bad catastrophic relapses or acquired damage. So, these are the kind of systems problems we have in the NHS. And we try to sort this out with, the Raising the Bar initiative in the MS Academy. Then I had my accident, so I just couldn't continue, so I pulled out. But I still, and then COVID came along, and we haven't sorted that out. We haven't sorted out any of the delays. I think the delays have got worse, actually, because of the manpower issues in the NHS. So these are big regrets, big regrets. I don't know how to sort them out. Can you sort them out, Agne?
Well, Gavin, with my positive mindset, I always look at the things from a bit of a different angle. All the failures are our life experiences anyway, and sometimes it's the wrong timing to implement any changes. If you look at backwards in the last 5 years, we all felt that the storm is coming, and that started, a decade ago since my arrival to the UK, and just looking at things, maybe, there is a time that hasn't arrived as yet, and we just need to wait a little bit to implement these changes. So I think if it is meant to be, it naturally happens to you without an effort. So this is the rule I apply in my life, and I think we are living the catastrophe at the moment, and we have to accept that and reflect. And later on in our lives, the situation will change, and it will be new challenges. But adapting to these new challenges, implementing, not being afraid and having fear of the change is my current mindset, and keeping everything positive, looking after ourselves, looking after our colleagues, our patients, making the patient at the center, and doing our best as we can. So moving on, Gavin, I would like to know what would be your advice to yourself when you're, let's say, 30 years old, and the place you were at the time, what you were doing? What would be your advice now, having all these failures and experiences in this life? What would be your advice now?
Yeah, so one of the things I probably would like to have done is more. I would have probably got involved. I would like to have got involved in public health a lot more. Being a jobbing neurologist, seeing one-on-one patients within a NHS system, you can do a lot for that individual, but you're not doing a lot for the population. And I think I didn't realize this back then, but I would have, I should have got involved with policy, public health a lot earlier, because I think you make a bigger difference at a systems level by doing policy. So setting quality standards, setting national audits, making people stick to those, you drive up. So I think, we're trying to do that now, but I think if I could have been involved 30 years ago with that, I think we'd be in a better place as a healthcare system now than we are. And so that's the first thing I should have done. I should have incorporated public health into my career earlier on, because I begin to realize now public health is so critical, how you change or set up healthcare systems. And then, as you know, I do a lot of public engagement, and I think what triggered myself to get involved was an anti-science movement. There was this thing called CCSVI where people thought blockage of veins caused MS, and it's been disproven, that thing. And you begin to see the power of information and how I think that's what we are. We are curators of information in a way in the current era. I should have probably done that a lot earlier, and maybe done it more professionally a lot earlier. So, I mean, that's one of the things we as healthcare professionals are pretty guilty of, is we tend to shy away from controversy and getting out there and speaking. And I think that's the wrong attitude to have. We have to get out there, because there are all these people promoting misinformation, disinformation, and they usually got a ulterior motive. It's usually driven by, they've got a company, they've got a product they want to sell. They've got a clinic they want you to come have procedure X or Y, and we as an MS community should get out there and say, no, this is a much better evidence base. I think it's changing now. I think people with multiple sclerosis are beginning to realize that they can assess now what's real and what's not real, which is taking time, which is good. So I think getting involved with better public education, I should have done it earlier when I was 30. I didn't do it when I was 30. I did it when I was in my late 40s.
Gavin, you're so talented, and I think you could find yourself being brilliant and high performer at any area of expertise or any industry, including business, maybe pharmacy, or anywhere basically. And my sort of thinking about you is, what topic would you speak about if you were asked to give a TED Talk on something outside your main area of expertise?
If I had to give a TED Talk, what do I give? I'd probably not talk about MS, but I'd probably talk about the social brain. How our brains are, as a species, designed for social interactions, and how important they are in terms of, we have a little garden and we've got to look after the garden, and part of that is, how do you make a healthy brain from social interactions? And I would probably want to talk about the social brain. This is one of the things that's been highlighted by COVID, and people are still don't appreciate, by self-isolation, by socially isolating themselves for what, when they're actually making themselves a lot worse long term, in terms of their own mental health. So I would talk about the social brain, and how important it is to have wide interests, because I think it's also important to keep yourself, have wide interests in terms of wellness. So, interacting with nature, interacting with family, reading widely, all these types of things that keep your brain healthier. I probably would work on something like that.
So TED organizers, if you're listening to this podcast, please send an invite to Professor Gavin Giovannoni to present his TED Talk on the social brain, and you will never regret his performance. It's going to be brilliant. So, Gavin, we could talk forever here about MS. It's never-ending topic for both of us, and we have such a passion to look after our patients, look at them more holistically. Today we discuss about the comprehensive review for people with MS, and we covered various different aspects and domains: how to optimize patients' management, how to tackle and look at the comorbidities, how to change the polypharmacy, how to be conscious about certain medicine that can worsen people's quality of life and outcomes. We also tackled the remyelinating agents and where we stand from that perspective. Also, we discussed about the classification and a new framework, and the McDonald's 2017 criteria that needs to be updated and upgraded following our discussions. I would like to continue these discussions with key stakeholders and implement these changes in the world, because that will make everyone's life more robust, more diagnostically accurate, and everyone is going to be happier making these decisions towards the diagnosis and making the plans for people to preserve the brain health. everything matters in this life, and I'm super grateful. Honestly, very much appreciated this conversation with Professor Gavin Giovannoni. I know how busy you are and how challenging it is for you to make the commitment and attend the podcasts and discuss issues. And we got some sort of a tradition here that my guests are asking questions at the end of the conversation for the following guest that comes to the show. So what would be your question to my following guest that is going to join me in a week's time to talk to me about the brain health? So what would be your question around the brain health? I'm not going to reveal who's my next guest, just to keep the intrigue going, but what is your question around the brain health living with MS?
So we know intermittent fasting, it has health benefits, and a lot of people with multiple sclerosis do. I would like to know, what if they walk the talk, if they do intermittent fasting themselves, and what protocol they use in terms of intermittent fasting. That's controversial. Okay.
Brilliant. Thank you so much, Gavin. Now, the question for you is from our previous guest, Colin Bannon, retired GP doctor living with MS, and nutritionist Sam Josephs. They both come up with a question asking, how do you tackle healthy lifestyle in your clinics when you have only 15 minutes per consultation? What do you do to tackle this issue in a short period of time?
Yeah, so I normally ask about their diets. I give them a little card on our brain health initiative, and I also tell them, I give them a little MS selfie card, and they can then search for diets on that. But I stress that they have to, improve their brain health, optimize it. And that means diet, exercise, and sleep. Those three things are critical, to be honest with you. If you're not eating well, you're not sleeping well, and you're not exercising, you're not going to do well. And this is not really applicable to people with MS. This is applicable to the whole population. You need to actually focus on those three. And then obviously, it's about asynchronous communication. I direct them to an online resource so that they can then self-activate. There's only so much you can do. I would love a clinic. I would love a wellness clinic. We tried to set up a wellness clinic, Agne, because when I first got to Barts in London, and we just couldn't get funding for it. At that stage, they just laughed at us. The NHS is not about prevention at that stage. I think now we may have a better chance of setting up a wellness clinic, where you have people go. It'll be group clinics where people come in and you go through these things in a lot more detail and give them the understanding why improving sleep, for example, is going to improve your outcomes. You know how badly people with MS sleep. We did a survey by our blog readers maybe 10 years ago, and it was over 80% of people had a sleep problem.
And they struggle throughout the day because of the fatigue level at daytime if they are not sleeping well at nighttime. So there is going to be another podcast on the sleep disorder and toolkit, how to sleep better throughout the night and maintain the sleep and fall asleep. So tune in and listen to another podcast that is being released. And my observation here is we have to work as a team. If we collaborate together, patients and healthcare providers, from our perspective, it's important to get information from you as a patient. So if you are coming to the clinical appointments, make sure that you're very well prepared. You probably come with a notebook or some sort of apps are around where you can track your symptoms. Anything helps to summarize your symptoms. When you come to the appointments, quite often there is a white coat syndrome and forgetfulness involved in cognitive issues that not necessarily you remember what you meant to highlight during the consultation. So recording that, whether it's a voice recording or you can write it down and get ready for your consultation. As a physicians and a healthcare providers, it's important for us to ask questions and look at the patient as a whole. More holistic approach is very important these days, because as you learn, the brain health and preserved brain health depends on multiple domains and factors in this life. So Thank you very much for listening to this podcast. It was an amazing opportunity to meet with Professor Gavin Giovannoni. It doesn't happen that often these days for me specifically, and I'm sure that Professor Gavin Giovannoni is in such a demand to meet and talk because such a bright minds are very rare in this world, and having this innovative approach of providing the care. Learning from the best in the world is rare opportunity for everyone, and these podcasts, the purpose of these podcasts is to learn, to educate, to feel that you're part of the community and you're doing the right things and the best things you can in this life. What gets measured gets managed usually. So we have to prepare ourselves, reserve our own energy, be healthy ourselves as a healthcare providers, and then educate people with MS. Thank you very much for listening. If you're not following Professor Gavin Giovannoni, please do. He's very active online on his Twitter, LinkedIn, and please follow and subscribe to his MS Selfie program. He uses a very simple, patient-friendly language to describe issues around MS, and up-to-date evidence-based information is being shared with you, so no-brainer not to have a subscription. You can have it free of charge, or you can pay a subscription to get up-to-date information on a weekly basis. So I'm very happy when I get an email from MS Selfie from Gavin Giovannoni. I know that he's doing very hard work to explain the current trends and situations and up-to-date information. So it's nice to be part of this tribe and community, and please do subscribe. If you have any comments following this recording, please do comment below on my media platforms. I read every single comment and I do respond as much as I can. Stay well, stay healthy as much as you can, and thank you, Gavin, for attending this podcast. That was enlightening my whole month, not just week or day. So this is something that I'm going to dwell and think about, and do appreciate for your input and your shared information and knowledge, deep knowledge with the whole rest MS community.
Pleasure.
So bye for now, and keep listening to my Be Well with MS podcast.